At MSC Sleep, the Sleep Support Department is comprised of 30 sleep coaches who help to troubleshoot PAP supplies, educate patients on best practices for PAP therapy, and maintaining compliance and assist patients in the refreshment of PAP supplies. For MSC to best service over 60,000 patients, we developed two different programs to help patients refresh their supplies according to their insurance guidelines. Our most convenient program is the auto ship program. A fresh set of supplies is automatically shipped to the patients once they are eligible for the next order of supplies. The second program is called Courtesy Contact. Courtesy Contact is where patients are notified via call, text, or email that they are due for their next shipment of supplies. MSC is now offering the ability to self-order through the SNAP app. This app gives patients the ability to check status of their orders, place an order with the click of a button, and update their personal information. To order supplies for any PAP patient or to learn more about the MSC Sleep Refresh program, visit medicalserviceco.com.
What a great presentation by Dr. Roy. Our next presenter for the sleep track is Dr. Donna Arand, who will provide another fascinating lecture. Dr. Arand is presently an associate research professor at the Wright State University School of Medicine. She is the past president of the Society of Behavioral Sleep Medicine and has served on the board of the American Academy of Sleep Medicine, as well as the board of registered polysonographic technologists. Dr. Arand has over 100 publications in the areas of insomnia, arousal, and performance. Speaking at the JSM Forum in the past, we are thankful to Dr. Arand for once again participating in our educational event. We also want to remind you that you can submit any questions you may have for Dr. Arand by using the Engage tab above the presentation screen. Enjoy her lecture on evaluating daytime sleepiness and alertness, updates of the MSLT and MWT.
Hello, thank you for joining me today. This presentation is on evaluating daytime sleepiness and alertness, along with the updates that were made to the MSLT and MWT. Now, in the early days of sleep medicine, a patient came into the sleep center at the urging of her family because she was falling asleep a lot during the day. The patient said that she did sleep a lot and she'd always done this, and it was completely normal for her. After testing, she was diagnosed with narcolepsy and started on stimulant medication. At her follow-up a month later, she was asked how she was doing. She started crying. She said, "I'm awake for the first time in my life, and I realized I've missed my entire life. I've seen the photos of family gatherings, holiday celebrations, weddings, and anniversaries, and I was there, but I don't remember any of it. Mostly I was asleep." Back then, heartbreaking stories like this were not uncommon. Individuals could go 30, 40, or 50 years without being diagnosed. Today, it's better. It's about 10 years between the onset of symptoms and diagnosis. However, while that's better, that's little comfort to the 5% of the population who has a chronic problem with excessive daytime sleepiness. Now, that translates to 15 million people in the United States alone. Sleepiness is the most common complaint evaluated in sleep disorders centers, primarily because there are a lot of obstructive sleep apnea patients who are seen there, and typically they have daytime sleepiness. In addition, some of them also have narcolepsy. So clearly, it's very important to be able to test and monitor for daytime sleepiness in the patient population at sleep centers. However, this can be very challenging because sleepiness is affected by so many things. It's affected by your behavior, whether you're normally in a sedentary situation or you're more physically active. It can also be affected by what you eat and drink. A heavy carb diet may produce sleepiness, and then consider the effects of alcohol versus caffeine that you may engage in during the day. It's also dependent on cognitive and physical demands of a situation. You can use your brain to help keep you awake by being very mentally alert, and also you can use your physical body to move around to increase alertness. In addition, sleepiness normally fluctuates during the day. Typically, it will change during the day due to sleep inertia. When you wake up in the morning, that grogginess you feel on awakening is the sleep chemistry changing over to the wake chemistry. For some of us, this is a really challenging time, and we may rely on the snooze button to get 5 more minutes of sleep before then again experiencing sleep inertia. In the afternoon, postprandial drowsiness is very common. This is that letdown in alertness and a little sleepiness that occurs following eating a meal. Some cultures have embraced this sleepiness with the siesta, which is a mid-afternoon nap that decreases sleepiness, and it also limits activity during the hottest part of the day. Finally, at bedtime, there's prodromal bedtime sleepiness. That's the sleepiness we start to feel as we get close to our bedtime. It's really a good thing and helps us fall asleep faster, although many of us can push through that and then find that we fall asleep watching TV or at our computer. In any case, these are common, normal fluctuations in sleepiness that we all experience every day. However, in addition, we may have periods during the day when we feel sleepy, and these usually occur in sedentary, boring, or monotonous situations, such as maybe listening to a presentation on hypersomnia while sitting at a desk in a quiet room. To improve your alertness, you may start working on another computer, and certainly you'll be monitoring your phone on the desks for important texts from families and friends. Multitasking is something that we all do, and it can increase our alertness and mask any sleepiness. However, there are other common remedies that many of us engage in. The most universally used remedy to fight sleepiness and increase alertness is caffeine, and more caffeine. Caffeine is universally used to increase our alertness. And in fact, coffee beans are the second most traded commodity in the world, right after oil. So while our cars run on gasoline, our bodies seem to be running on caffeine. So most of us, when we wake up in the morning, we go downstairs and get our cup of coffee, or we might drive to work and go to the drive-through at Starbucks to get our espresso or our lattes. Still, some of us get to work and head right for the break room and the coffee pot there. Caffeine is commonly used to start our days. However, what you got to realize is that caffeine has a very short half-life, about 3 hours. So you're going to need another cup of coffee at lunchtime or in the early afternoon to get that same level of alertness you got earlier in the day. Additionally, tolerance to caffeine develops very quickly, usually in about 3 or 4 days. So the caffeine that you drank on Monday is not going to give you the same effect on Thursday. You're going to have to make your latte a grande and your espresso a double to get the same impact from the caffeine. It used to be that 1 cup of coffee made at home had 100 milligrams of caffeine in, but now some of the Starbucks drinks have 700 or 800 milligrams of caffeine. And of course, the teenagers are using energy drinks, which are loaded with caffeine to help increase their alertness. So should we consider this universal drinking of coffee to be normal, even though caffeine is a stimulant? Or does this represent an epidemic of sleepiness throughout the population? These are questions that we wrestle with when we're dealing with measurement of hypersomnia in the population. There are other things that we can use to help us keep alert, and that is just standing up, moving, walking, just getting active. That will stimulate our arousal system. Some people find that eating helps increase their alertness, while others engage in conversation, which mental stimulation will also increase alertness and mask our sleepiness. Finally, simply going outside can increase alertness, not only because we're moving around, but because the sun is actually having an arousing effect on our body. It suppresses melatonin, which is the sleep hormone. Now, obviously, alertness is important for our daily functioning, particularly school and work performance. This is why we engage in these various remedies that are socially acceptable. Our alertness is also needed to socialize with our family and friends, and it's important to avoiding occupational and auto accidents. AAA indicates that 328,000 auto accidents occur every year just due to fatigue, and 6,500 deaths can be attributed to drowsy driving. The CDC has also reported that 1 in 25 drivers admit to falling asleep behind the wheel in the previous 30 days. So clearly, alertness is necessary for our general health and for our well-being. However, while most people would like to consider sleepiness and alertness on a continuum, with sleepiness at one end and alertness at the other. And ideally, you'd want to be able to place yourself at some point on this line throughout the day. And generally, you'd expect in the evening you'd be moving more towards sleepiness. However, that's really not the case. You could be very sleepy at bedtime, and then all of a sudden somebody yells fire. You're now very alert, your adrenaline has been released, and you're moving around very quickly. But your sleepiness underlying your activities is still the same. It's still there. It's sort of like being drunk and almost passing out, and then somebody gives you caffeine and you seem to wake up and seem less drunk, but your blood alcohol level has not changed. You're still drunk. In the same way, sleepiness can be masked by our activities and change depending on the situation at hand. So sleepiness and alertness are really not on a continuum. They're separate characteristics. They can change separately, and so they can be measured differently. And that's what we are trying to do in the sleep centers. If we look at the history of measuring sleepiness and alertness, we find that before 1968, it was really based mostly on behavioral observation. If a person was laying down or their eyes were closed, they didn't move, you called their name and they didn't respond, you determined they were asleep. And that worked pretty well, and we still use that today. However, in 1968, following the development of the polygraph, the EEG was used to quantify stages of sleep and allowed us to measure sleep onset. This was the first time we could objectively look at sleep and measure various sleep stages and sleep latencies. After this, sleep centers started to proliferate, and in 1972, the Stanford Sleepiness Scale was developed. Now, this was a 7-option Likert scale that asked one question, basically, how sleepy are you at this point in time? And the options varied from 1 being fully awake and alert to 4 somewhat groggy and to 7 fighting sleepiness, having dreamlike images. So you could use this subjective scale to determine how sleepy you were at a given point in time. But for sleep labs, that really wasn't so great because they wanted an objective measure and they wanted something that measured more than one single moment of the day. So in 1977, the multiple sleep latency test procedure was developed, and this involved giving multiple naps during the day and just looking at the sleep latency across the day and using that measure as a measure of an individual's sleepiness. This was wonderful because it provided an objective measure of sleepiness for the first time. And when it began being used in sleep centers, they quickly found out that in narcolepsy patients, they often went into REM sleep on these very short naps. So the combination of REM sleep and short sleep latencies was ultimately used to set criteria for diagnosis of narcolepsy. However, one thing the MSLT didn't do very well was show improvement in the sleep latencies after the patients had been treated. The patients reported feeling more alert, not having as much problem with sleepiness, but yet the MSLT latencies didn't really change that much, or as much as you would expect given the patient reports that were being heard. So then in 1982, the maintenance of wakefulness test was developed, And this test was basically an MSLT with nap trials during the day, except the patients were told to try to stay awake. It finally dawned on us that asking a person to stay awake was a better indication of their alertness than asking them to try to fall asleep. So the MSLT and MWT became very useful tests and in sleep disorder centers, and they were used quite frequently. However, the problem with them was that they were expensive and they were very inconvenient for the patients, particularly the MSLT, which required them to stay in the lab all night for a PSG, as well as the next day for the MSLT. So in 1991, in Epworth, New Zealand, Murray-Johns developed and published the Epworth Sleepiness Scale. Now, this was a questionnaire scale that described 8 typical situations that the patient rated on a scale of 0 to 3 for their usual chance of dozing off. The situations included things like sitting and reading, or watching TV, or being a passenger in a car for an hour without a break. The scores could range from 0 to 24. And this scale was so popular, it was translated in many languages and used worldwide in clinical and research settings. In fact, it's still used today, and many research studies have replaced the MSLT with the Epworth Sleepiness Scale. And it's now also required by many payers prior to authorizing sleep testing for patients. However, there are many concerns with the Epworth Sleepiness Scale. First of all, it's a self-administered test, so it's has a lot of subjective bias associated with it, and it can depend on how the person feels at the moment or what just happened to them. There's also no clear description of what is meant by low, moderate, or high chance of dozing. So for one individual, a situation with a moderate chance of dozing, that same chance of dozing may be considered a high chance of dozing for another individual. The Epworth also asks about the prior month, so it's affected by memories and activities that you've been engaging in the previous 30 days. So if you've been on vacation in Hawaii, your Epworth Sleepiness Scale is probably going to be very different than if you were in a sports tournament for a couple of weeks. Finally, at least one study has shown that over a 6-month period, 21% of patients scores on the Epworth differed by 5 points or more. So the stability of the Epworth Sleepiness Scale is definitely in question. In comparison to the Epworth, the reliability of the MSLT is extremely high. If you look at studies that have tested the retest reliability of the MSLT, we find that in normal individuals over a 4 to 14 month period, 97% of the MSLT showed similar sleep latencies when retested. In narcolepsy patients, 93% of them showed 2 or more sleep onset REM periods when they were retested using the MSLT. Now, both the MSLT and MWT rely exclusively on scoring sleep. So the latency to sleep will vary if the scoring is inaccurate. So studies have looked at the scoring reliability and found it to be very high, ranging from 0.78 to 0.91 for both reliability between different scorers scoring the same test, and one individual scorer rescoring the test. So the reliability of the MSLT is very high. However, this 0.97 reliability will change based on the number of naps done. If 4 naps are done, the mean sleep latency reliability is 97%. However, this drops to 85% if you only do 3 naps, and reaches a low of 65% if only 2 naps are done. So the more naps, the more reliable the mean sleep latency is. Now, the validity of the MSLT and MWT is somewhat difficult to describe because these tests are both the gold standards for evaluating sleepiness and alertness, respectively. So there's nothing to compare them to say, yes, they're valid or no, they're not. So the validity of these tests relies on the face validity, which is basically that the basis of the test makes sense and the test moves in the directions you would expect in different circumstances. And when you look at the MSLT and MWT, both of them rely on accepting sleep latency as a measure of sleepiness. And that makes intuitive sense. The sleepier you are, the more likely you are to fall asleep faster. The tests also show a decreased latency following sleep deprivation and following the use of hypnotics and sleep-promoting agents, which is exactly what you'd expect. Finally, both tests show increases in sleep latency following the use of stimulants, also what you expect. So based on face validity, both tests are very valid. If you look at the correlation between the mean sleep latency on the two tests, we find that it's 0.41 between the MSLT and MWT. That only accounts for 16% of the variance between tests, and that's very low. And what that means is that while there's some relationship between the two test results, they are actually measuring very different things. So what do they measure? The MSLT measures the tendency to fall asleep, while the MWT measures the ability to stay awake. They're used for different things. The MSLT compares the mean sleep latency with diagnostic criteria. It also documents REM onsets in narcolepsy patients. And it shows changes following interventions, although, as we indicated, it's not really good at doing that. By comparison, the MWT compares sleep latency to controls. It also shows change following interventions. And we're going to look at some of the factors that affect sleep latency. Generally, these can be grouped into three categories, some of which we can control and some of which we can't. The first category is patient characteristics. These are things we can't control: the patient's age and the patient's circadian rhythm. Procedurally, there are factors that need to be controlled, such as the sleep latency definition, the number of naps done, and the test instructions. Following strict protocols, we're able to control these procedural variables so they don't add extraneous variability to the scores that we're obtaining. Finally, behavioral factors are more difficult to control, but we do try to do that through the protocols for the tests we're giving. Behavioral factors include the activity immediately prior to a nap or wake trial, the use of caffeine stimulants, depressants, or marijuana, and finally, sleep deprivation. We attempt to control all of these things in order to get an accurate and stable measure of sleep latencies for measuring sleepiness or alertness. And we're going to look at how some of these factors affect the mean sleep latency and how big an impact some of them can have if they're not controlled. If we look at age effects, which is something that we can't control in the tests, you find that from age 10 to age 80, the mean sleep latency in normal individuals increases. It increases by 0.6 minutes per decade of life. If you look at the circadian effects on the MSLT, we find there's a last nap effect, which refers to the fact that the last nap or trial in the test always has a longer sleep latency. We think this may be due to the patients being excited and anxious to go home after a long day in the sleep lab. Also, sleep onset REM periods are more likely to occur in the morning trials in normal populations. This is due to the fact that REM sleep increases in the last half of the night, and this increase and higher percentage of REM sleep continues through the morning hours, whereas in the afternoon, it's more likely to see slow wave sleep. Finally, nocturnal MSLTs done on third shift workers show that latencies decrease across the night and are lower than during the daytime hours. Also, the effect of 4 versus 5 naps on the MSLT also shows that there's a difference. If you give 4 naps, a 4-nap MSLT to normal individuals, they have a sleep latency of around 10.3 minutes. If you give 5 naps to these same individuals, the latency increases over a minute to 11.5 minutes. We think this increase of about a minute is really due to a more exaggerated last night nap effect with the 5-nap protocol. At 5 naps, not only is the individual eager to go home, but it's also close to dinner time. If you look at the effect of sleep deprivation on sleep latency, it's exactly what you'd anticipate. In one study, the baseline in normals was 13.4 minutes on the MSLT, but when their nighttime sleep was reduced by 50%, their mean sleep latency dropped to 3.8 minutes, definitely in the pathological range and around the average in narcolepsy patients. And it shouldn't surprise anybody that the less sleep you get at night, the sleepier you're going to be during the day, so sleep latencies would decrease. And in this case, you can see that they can actually fall into the very pathological range. Now, the activity immediately prior to a nap or wake trial also affects the sleep latency, and it can do quite a bit of, it can have quite a large effect. In 2 different studies, the latencies were compared after an individual did a 5-minute walk around the sleep lab versus 15 minutes of watching TV or resting in bed. And what they found was that walking around for 5 minutes resulted in a mean sleep latency of 11.6 on the MSLT, whereas watching TV reduced that latency to only 5.8 minutes. Another study similar to that showed 11.7 minute latency after walking around for 5 minutes compared to 7.1 minutes while resting in bed. Clearly, there's an impact of immediate activity on the sleep latency. Now, this study looked at the effect of instructions and position on sleep latency. In these normal individuals, they were laying down and told to stay awake, in which case their sleep latency was almost 18 minutes. When they were laying down and told to try to fall asleep, their latency dropped to 11 minutes. However, when they were sitting up and told to stay awake, they had a high sleep latency of 29 minutes compared to being sitting up and being told to try to fall asleep, which again, their sleep latency dropped a little to 21.7 minutes. So as you can see, laying down always produces lower sleep latencies or shorter sleep latencies than sitting up. Position makes a difference in the sleep latency. Interestingly, sitting up and being told to stay awake was had the same sleep latency pretty much as sitting up and working on a computer. So clearly, instructions and body position affect the sleep latency. So all of these factors have been studied, and the update of the MSLT and MWT paper, which came out in 2021, attempted to look at all of these variables and to use them as evidence for modifying or clarifying aspects of the MSLT and MWT to help improve their ability to diagnose patients. This paper addressed total sleep time in the 2 weeks prior to testing, which had not been covered in the prior 2005 paper. It also looked at the use of caffeine or withdrawal of caffeine medication and substances prior to testing. It addressed documentation and use of PAP in OSA patients. It looked at common drugs affecting sleep latency, or REM. It set out optimum test conditions for both the MSLT and MWT. It corrected discrepancies with the scoring manual, and it increased the information that was recommended in the MSLT and MWT reports. What it didn't address was normative data or diagnostic criteria. Now, the diagnostic criteria is set in the ICSD-3, which is a separate international publication. This paper also did not look at the use of the MWT for evaluating safety and risk in patients and high-risk occupations. So we're going to look at some of the changes or enhancements that were made to the descriptions of the MSLT and MWT. And those changes are in red type. And the first thing we're going to look at is the patient preparation 2 weeks prior to the MSLT. The new paper suggests that sleep diaries be used for 2 weeks, not just one, for 2 weeks, and that they show at least 6 hours of nightly sleep, preferably 7 hours in the 2 weeks prior to testing. It also suggests having a discussion between the clinician and the patient about acceptable caffeine consumption. A plan needs to be agreed on because, as I mentioned, caffeine is universally used, and if you suddenly withdraw caffeine, you may have headaches or other side effects, and we certainly don't want that impacting the MSLT or MWT if caffeine isn't allowed on those days. So looking at the amount of caffeine that is being used by the patient may require some withdrawal and possibly even stopping caffeine prior to coming in for the MSLT or MWT. Medication with stimulating, sedating, or REM effects needs to be discontinued 2 weeks before, or we're finding in many cases patients are on chronic medications that cannot be discontinued. So we indicated that it just needs to be stabilized in the 2 weeks before the test. Also, the use of over-the-counter substances is discussed, including the use of marijuana, which is more common nowadays. And interestingly, marijuana has an extremely long half-life and can be detected in the blood months after the last exposure to marijuana. Now, there are also some special patient preparations in the 2 weeks prior to an MSLT for patients who are on PAP. For these patients, PAP needs to be used regularly with PAP adherence and effectiveness verified with a PAP download, or verbally for non-PAP treatments such as oral appliances. And this needs to be to cover at least the 2 weeks prior to the MSLT. Additionally, CPAP should be used nightly for at least 6 hours prior to the MSLT. 4 hours isn't adequate enough. 4 hours is really the minimum requirement needed or set by insurance companies to continue paying for CPAP and supplies. However, studies have shown that the more hours that CPAP is used, the greater decrease in sleepiness. And this decrease continues for up to 6 months prior to starting CPAP. Prior PSG must show that the CPAP was effective, and the MSLT should never follow a split night PSG. Now, the MSLT procedure in general states that it follows a PSG, which is required, and there must be now a minimum of 7 hours of recording time in the PSG with at least 6 hours of sleep during the patient's normal sleep period. 7 hours was encouraged since to get 6 hours of sleep, you need to be recording for more than 7 hours since nobody has 100% sleep efficiency. So it was set at 7 hours minimum to make sure that the individual isn't sleep deprived. Additionally, those on PAP and non-PAP therapy should be using it during the previous or the prior night's PSG as well as during the nap trials. The procedure consists of 4 to 5 naps given 2 hours apart, beginning an hour and a half to 3 hours after the start at the end of the PSG, and the naps are terminated after 20 minutes if there's no sleep, or after 15 minutes if sleep occurs. Audio-visual recording is required during the naps with monitoring throughout the day. On the day of the test, there's no alcohol, marijuana, or sedating or alerting agents allowed unless they're part of a treatment plan and their effectiveness is being evaluated. There's also no strenuous activity during the day or prolonged exposure to sunlight, which can obviously increase alertness. Urine drug screens are optional, and they can be done on the day of the test or a couple days prior, since many sleep centers are not able to perform and collect lab specimens in their facility. A change of clothes between the PSG and MSLT is not required. For the MSLT recording, it's now required to also include frontal derivations for the EEG. So F3M2 or F4M1 must be included in the recording. Additionally, A1 and A2 references have now been changed to M1 and M2 to indicate mastoid placement. EOGs, EMG, and EKG are still required, but additional sensors from the PSG should be removed prior to doing an MSLT. Audio-visual recording during the naps is required. Now, before you can start the nap, stimulating activities, including the use of electronic devices and cell phones, must end at least 30 minutes before each nap trial. Previously, some activities had to end 15 minutes before the start of a nap and others 30 minutes before. Now they're all consistently 30 minutes prior to the nap and do include electronic devices and cell phones. Patients on PAP should use CPAP during each nap trial. For the trials, the patient lies down in bed in a quiet, dark room, and biocals are done, and these should take a couple minutes. This time allows the arousal system to stabilize before starting the nap. At the start of each nap, the instructions have changed slightly to please lie quietly, assume a comfortable position, keep your eyes closed, and allow yourself to fall asleep. Previously, the directions indicated that you should try to fall asleep. But as we know, we can't make ourselves fall asleep, and it was thought that telling someone to try to fall asleep could be frustrating for them if they couldn't fall asleep, or produce a lot of anxiety and result in a change in the mean sleep latency. So that instruction is now to allow yourself to fall asleep. The lights are out and the recording then begins. The nap is terminated after 20 minutes if there is no sleep, or 15 minutes after the first epoch of any stage of sleep. And that's simple clock time. So even if the patient wakes up after initially falling asleep, that wake time is still included in the 15 minutes. MSLT scoring has not changed. The 4 or 5 naps are used to calculate a mean sleep latency, a REM latency, and the number of naps with REM sleep. Sleep latency is defined as the time from lights out to the first epoch of any stage of sleep, and REM latency is determined from the first epoch of sleep to the first epoch of REM. The MSLT needs to be interpreted within the context of the patient's sleep history. The diagnosis is a clinical decision, and the MSLT can support that clinical decision. However, if we look at the diagnostic criteria based on the MSLT, the ICSD-3 states that a mean sleep latency of less than or equal to 8 minutes is needed, along with 2 or more sleep onset REM periods, including in the PSG. If you look at how well this diagnostic criteria is effective in diagnosing narcolepsy, you find that 94.5% of narcolepsy patients will have a mean sleep latency less than or equal to 8 minutes. Additionally, 79% of them will have 2 or more sleep onset REM periods. And this 79% increases to 98% if those narcolepsy patients who didn't have 2 SOREMs on an MSLT have a repeat MSLT. Then 98% of them will have 2 sleep onset REM periods. If you then look at how well these criteria distinguish a normal population from narcolepsy, you find that 73.3% of normals will not have a sleep latency less than 8 minutes, and 98% will not have 2 or more sleep onset REM periods. Now, these numbers aren't perfect. They're not 100%, and there's some reasons for these false positive results. The cause of false positive mean sleep latencies less than 8 minutes can be due to acute or chronic sleep deprivation or untreated sleep disorders. Additionally, sleep onset REM periods can occur in untreated obstructive sleep apnea patients. One study has shown that 29% of untreated OSA patients have sleep onset REM periods. Also, the recent discontinuation of REM suppressing medications or REM deprivation can cause sleep onset REM periods because there's an increased pressure for REM sleep. REM can occur earlier in the sleep periods. If you look at the ICSD-3 criteria for diagnosing idiopathic hypersomnia, it states that there must be a mean sleep latency less than or equal to 8 minutes, just like in narcolepsy. 8 minutes is the cutoff for pathological sleepiness. And there should be less than 2 sleep onset REM periods, including the PSG. Now, if we look at how well this criteria, mean sleep latency of less than 8 minutes, works for diagnosing idiopathic hypersomnia, we find that a mean sleep latency in narcolepsy is 3.1 minutes. In an idiopathic hypersomnia population, that's doubled to 6.2 minutes compared to normals that are either 10 or 11 minute latencies, depending on whether there's 4 or 5 naps. So the mean sleep latencies are less than the pathological range for these hypersomnia groups. However, when you look at the standard deviation and add that to these means, you find that a range of mean sleep latencies in a narcolepsy population is 0 to 8.9 minutes. So clearly, most narcolepsy patients would fall below the 8-minute cutoff. In idiopathic hypersomnia, the range is about 0 to 12 minutes. Some of these patients will fall above the 8-minute criteria and not be diagnosed. Finally, in normal controls, the values range from about 1 or 2 to almost 20 minutes. Clearly, some of these normal controls will fall into the pathological range and be misdiagnosed. So clearly, the mean sleep latency from the MSLT does not discretely distinguish normal from pathologically sleepy populations. However, it's unlikely that a patient without a problem with daytime sleepiness would be having an MSLT. So it's unlikely that we will find so many patients being pathologically sleepy on a test when in fact they're in a part of a normal control population. So it becomes very important to look at the history and the complaint about sleepiness when both ordering these tests and when interpreting them. Now, if we look at MWT and the evaluation of alertness, the validity of the MWT has more face validity for evaluating an individual's ability to stay awake than the MSLT, simply because it asks the person to try to stay awake in multiple trials during the day. However, the validity of the MWT results for evaluating safety is still not established. The general procedure for the MWT is that an optional PSG can be done prior to the test, but it is not required. Use of caffeine, tobacco, or medication is based on a clinical decision, since this test may be used to evaluate its effectiveness. The MWT consists of 4 40-minute trials given 2 hours apart, and the first trial begins an hour and a half to 3 hours after the usual wake-up time. The patient sits up in bed or in a recliner in a quiet room. There's a night light in the room, and trials are terminated after 40 minutes if no sleep, or 3 consecutive epochs of stage 1, or 1 epoch of any other stage of sleep. Drug screens are optional in the morning or after the test, and audio-visual recording during the trial is required. In the 2 weeks prior to the test, the patient should have adequate sleep that's documented with sleep diaries. An acceptable caffeine consumption plan needs to be agreed on, and the clinician needs to develop a plan for the use of prescription medications and other substances, and chronically taken medications with alerting or sedating properties need to be at a stable dose. In patients on PAP, PAP adherence and effectiveness needs to be verified with a download or verbally for non-PAP treatments for at least 2 weeks prior. Patients should use PAP or non-PAP treatment the night before, and PAP should not be used in MWT trials, and the MWT should not follow a titration or split night PSG. The PSG is optional before the MWT, and there are reasons you might want to do it. For example, if the patient is malingering or motivated to fail the test, or there's a suspicion of an underlying sleep disorder. Otherwise, if there's no suspicion of an underlying sleep disorder, or it's been effectively treated and the patient indicates sleepiness is not a problem and they're motivated to pass the test, the PSG is probably not needed. The day of the test, no alcohol, marijuana, or sedating or alerting agents unless it's part of the treatment being evaluated by the test. No strenuous activity, prolonged exposure to light, and a urine drug screen is optional before or after the test, and a change of clothes between a PSG and MWT is not required. Recording parameters are the same as the MSLT and now include F3 or F4 EEG derivations and a change from A1 and A2 to M1 and M2 references. Audio-visual recording during trials is required with monitoring through the day. To start the trial, stimulating activities, including the use of electronic devices and cell phones, ends at least 30 minutes before each trial. The patient can sit in bed or in a recliner chair. Biocals are done and the patient is instructed to please sit and remain awake for as long as possible, look directly ahead of you, and do not look directly at the light. The lights in the room are turned out and the recording begins, and the trials are terminated after 40 minutes of no sleep or 3 consecutive epochs of stage 1 or the first epoch of any other stage of sleep. The MWT is scored using 4 trials to calculate the mean sleep latency, which is defined as the time from lights out to the first epoch of any stage of sleep. And this is different than the termination of the trial, which could require 3 consecutive epochs of stage 1. Interpreting the MWT is a little challenging because it's not a diagnostic test and the results are compared with normative data or a prior MWT and must be interpreted within the context of the patient's sleep history. If you look at the normative data that the MWT is compared to, you see that the mean sleep latency in normals is 30.4 minutes. There's a large standard deviation resulting in a range of values between 8 and 40 minutes. Below 8 minutes is in the range of pathological sleepiness, and probably these individuals should have had an MSLT. However, while this range is very large, turns out that 42% of normals don't fall asleep on any trial of the MWT, so their mean sleep latency is 40 minutes. Now, if we look at the summary of changes for the MSLT and MWT, we now require 2 weeks of a sleep diary, the additional frontal EEG location, change from A1 and A2 to M1 and M2 references, and all activities terminate 30 minutes prior. The same holds true for the MWT, with the addition that they may sit in a recliner or in a bed. There were some report enhancements suggested, including the addition of a BMI and medical record number on the reports, since everyone uses electronic medical records, and many of the tests and lab results will be found there, and those are needed for interpreting the MSLT. It should also indicate if any drug testing was done, what type. It should list medications in the 24 hours before and the day of the test, as well as any changes to meds in the last 2 weeks. The availability of sleep lugs, actigraphy, or PAP downloads should be indicated, as well as whether a sleep onset REM period occurred. Future studies are needed for determining large normative data for both tests. Shift work studies are needed for both tests. Driving and occupational safety studies are needed for the MWT. Age-specific diagnostic criteria should be considered for the MSLT. And finally, the development of simpler and inexpensive tests for sleepiness and alertness based on hormones or biochemistry are needed, similar to hypocretin, although that is not simple and it is an expensive test. Thank you.
Thank you, Dr. Arand. Welcome to the second breakout session Q&A audience. Welcome back. I'm joined live by Dr. Donna Arand. Thank you for that presentation on evaluating daytime sleepiness and alertness. And I think certainly the caffeine consumption portion of that presentation struck home with me, Dr. Arand. So thank you for sharing your expertise there. We do have some questions from the audience. My name, again, is Brent Mayberger, Director of Partnerships, Medical Service Company. And thank you all for joining us this afternoon. So our first question from the audience, Doctor, is what can respiratory care professionals look for to recognize signs of excessive sleepiness comorbidities that affect compliance with CPAP and BiPAP machines?
Well, I think objectively, the first thing that they can look at is the download from the CPAP or BiPAP machine to look at how long the patient is sleeping at night. If it seems to be excessive, 9, 10, 11 hours of using CPAP, or they're using it during nap times during the day, you might want to think there's something wrong. Other than that objective measure, the best thing to do is simply talk to the patient and a family member, if possible, and ask them how they're feeling after being on CPAP. Are they able to function well during the day? Are they alert? And then sort of get confirmation from other family members to make sure that you're not missing signs that the person is sort of dozing off during the day and at other times. And other than that, you really have to depend on the patient's report of how they're feeling and how things are going. Now, if an objective download, you find that the patient isn't sleeping much, or it appears that they're taking a long time to fall asleep, they may have insomnia that may have been triggered by the use of PAP, the mask, the pressure, a variety of factors. So those should trigger queries to the patient concerning their ability to fall asleep, and if the CPAP machine is creating problems with insomnia or aggravating maybe insomnia that was present prior to treatment with PAP.
Thank you, Dr. Arand. And to that point, at what point do you recommend MWT for a patient who is compliant with a PAP device?
Well, actually, I wouldn't routinely do an MWT in a PAP patient. I would, however, consider doing that in patients who are maybe in high-risk occupations or who have been prone to having lots of injuries or accidents during the day, at work, at home, in whatever situation. At that point, I would wait to do an MWT until the patient has been compliant with CPAP, and the insurers require at least 30 consecutive days of CPAP use. So at some point after 30 days, I would talk to the patient, ask them how they're doing, if they have any symptoms, and if they are functioning well during the day and they haven't had additional accidents, if that was a problem before, then I may not do an MWT. However, if they're in an occupation that is high risk, such as driving a truck or being an air traffic controller, those types of high-risk occupations, I may want to do an MWT, and that's often requested either by the employer or maybe by some governing board that has been notified the patient is on CPAP and they need evidence that that the patient is able to continue in their occupation. And the MWT at least provides an objective way of supporting the physician or clinician's decision as to whether or not this patient is okay to return to their work.
Doctor, is there empirical data regarding the percentage of patients who try and fail PAP therapy due to underlying sleep disorders?
Well, I'm not aware of specific data in that regard. However, we do know that 40 to 60% of patients do not continue on with CPAP, and they may discontinue CPAP early on or even after a year of starting it. So 40 to 60% of patients discontinue it. If you assume 1/3 of them may have a sleep problem, or at least 20%, you're looking at maybe 15 to 20% of these patients who may have an underlying sleep disorder, in addition to the apnea or sleep disordered breathing problem that they're being treated with. Using their PAP device or some version of that.
Yeah, that's great. Thank you, doctor. We've got time for one more question on an MSLT nap. If the patient falls asleep on epoch 1, is the nap stopped? Is it stopped at 15 minutes?
No, it does stop at 15. It would stop at 15 minutes if they fell asleep on epoch 1. It's not stopped at epoch 1 because they fell asleep. You would go 15 minutes from that first epoch of sleep, and if that's, you turn on the machine and they're in stage 1 already, you're there. So you then measure clock time, 15 minutes, and that also includes any wake time that may occur after the patient has fallen asleep. They may wake up for a few more minutes before going back to sleep. It's simple clock time, so that wake period after they've fallen asleep is included in that total 15 minutes of time.
Got it. Dr. Arand, thank you so much for sharing your knowledge and your expertise this afternoon. It's always a pleasure speaking to a fellow Daytonian and Wright State Raider. So thank you so much for spending time with us this afternoon. Look forward to having you back next year, and have a great holiday season. Thank you so much.
Thank you. Goodbye, everyone.
Bye.